This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Acta Neurochirurgica, published in 2026, titled A Simple and Aesthetically Pleasing Floating Craniotomy, How I Do It. It's a technical note by Tianzin Li and colleagues from the Army Medical University in Chongqing.
This is a timely topic, Ilara. We've all seen the high morbidity associated with the traditional two-step approach, the initial decompressive craniectomy followed months later by a cranioplasty. While the recent landmark trials have really scrutinized the outcomes of DC and traumatic brain injury, the search for a middle ground continues. We want the intracranial pressure control of a craniectomy, but the protection and cosmesis of an immediate bone replacement.
Exactly. The author suggests that instead of discarding the bone flap or putting it in a freezer, we can let it float. They propose a method using surgeon's knots and adjustable slip knots to create a buffer zone for brain swelling.
It's an elegant application of the Monroe-Kelly doctrine. We know that the combined volume of blood, CSF, and brain tissue is constant. By allowing the bone flap to elevate, we are essentially expanding that rigid container to accommodate edema. But let's get into the how. Walk us through the initial surgical steps.
It starts with a standard large craniotomy. The authors emphasize that the bone flap must be at least 12 by 15 centimeters. You also have to ensure adequate temporal decompression by removing the temporal squama and the lesser sphenoid wing down to the floor of the middle cranial fossa.
That's a critical point for the residents listening. A floating flap isn't an excuse for a small opening. You still need that middle fossa decompression. What about the dura?
They recommend a stellate or curvilinear dural opening. If, after your intradural work, the brain swelling is mild, specifically if it doesn't exceed the cranial surface and the ICP remains under 10 millimeters after replacing the flap, that's your window to proceed with the floating technique.
Okay, so the flap is back on. Now, the fixation is where this paper gets really interesting. They use 3 specific points of fixation, right?
Correct. They use a 1 millimeter high-speed burr to create 3 sets of drill holes, distributed symmetrically in the frontal, parietal, and occipital regions. But the knots used at these sites are not the same.
Let's break those down. The frontal site is different from the others.
Yes, at the frontal position, about 1 centimeter from the bone edge, they use a non-absorbable 0-0 Prolene suture tied with a standard surgeon's knot. But they don't pull it tight. They leave a relatively large loop. This acts like a tether. It allows the flap to move upward as the brain swells, but prevents the flap from sliding or displacing too far.
And then for the parietal and occipital sites, they transition to a more adjustable approach.
This is the clever part. They use slip knots. They leave at least 2 centimeters of slack in these sutures to permit that outward bone flap excursion. But here's the key. They exteriorize both ends of these slip knot sutures through the scalp.
So you have suture ends sitting outside the skin?
Precisely. This allows for post-operative adjustment without going back to the OR. But before they close, they add one more safety feature, a titanium plate.
Right, I saw that in Figure 1C. They secure one end of a titanium plate to the bone flap with a single screw, usually at the parietal or occipital region. Why just one end?
It's designed to prevent delayed flap subsidence. It acts as a mechanical stop so the bone flap can't sink inward past the skull's natural contour once the edema resolves.
Before we move to the post-op phase, I wanted to mention the scalp work they describe. They highlight the importance of the 5 layers: skin, subcutaneous tissue, gallia, loose areolar tissue, and pericranium. They recommend blunt dissection in the loose areolar layer.
Right, mobilizing that subgaleal plane increases scalp mobility and compliance. If the scalp is too tight, the bone flap can't float outward, and you lose the whole benefit of the decompression.
So the surgery is over. The flap is loosely tethered, and the slip knot ends are poking through the scalp. How do they manage these patients on the floor?
Post-operatively, it's about monitoring and patience. They perform dressing changes every 2 to 3 days. They include a great case example where on post-operative day 3, the CT showed significant edema and a well-elevated floating flap. By day 9, the edema was resolving.
And that's when they intervene.
Exactly. Once imaging and clinical assessment show the edema has settled, they apply an elastic compression bandage to gently guide the bone flap back to its anatomical position. Then they tighten those externalized slip knots.
This is a delicate maneuver. How exactly do they tension those sutures through the skin?
They describe using 2 hemostats. You stabilize one suture limb with the first hemostat and use the second to gradually tension the contralateral limb. This pulls the flap tight against the cranium. They keep the elastic bandage on for another 2 to 3 weeks after that to ensure the flap is fully secured while it starts to heal.
It really solves that sunken bone flap or syndrome of the trephined issue we see with open craniectomies. The cosmetic results in the paper look excellent. Their 3-week clinical photograph shows a completely normal head contour, no secondary cranioplasty required.
It definitely saves the patient a second major surgery. However, we should talk about the limitations. The authors are very clear that this is not a one-size-fits-all technique.
Right. This isn't for your malignant MCA infarcts. The paper explicitly states that the limited decompressive volume of a floating flap might be inadequate for fulminant or malignant cerebral edema.
They suggest it's best for cases like traumatic intracranial hematomas, where you expect some swelling, but not the kind of massive herniation risk where the bone absolutely must come off.
They also list some very specific strategies for complication avoidance. Patient selection is number 1. Number 2 is positioning the drill holes away from major vessels in avascular regions. You don't want a suture pull-through to cause a dural sinus tear.
They also emphasize meticulous hemostats and protective postoperative positioning. You obviously can't have the patient lying directly on the operative side while the flap is floating.
And infection control. Having sutures exteriorized through the scalp usually makes neurosurgeons a bit nervous. They advocate for strict aseptic technique and standardized antibiotic use. Ilara, did they mention any specific perioperative considerations?
Just the importance of comprehensive informed consent. You have to explain to the family that the bone flap will look slightly elevated or floating for a week or 2, and that there's a bedside procedure to tighten it later.
It's a fascinating refinement of the hinged or floating craniotomy techniques we've seen in the past. To summarize the key technical points, a 12 by 15 centimeter flap, temporal decompression, 3-point fixation with Prolene, specifically that frontal surgeon's knot loop, and the 2 posterior adjustable slip knots, and that single-ended titanium plate to prevent subsidence.
And don't forget the subgaleal dissection for scalp compliance. It's a simple set of modifications, but the ability to definitively secure the flap without a second trip to the OR is a huge potential win for patient care.
Absolutely. It's about being aesthetically pleasing, but more importantly, it's about reducing the overall surgical burden on the patient. Well, that's our deep dive into the 2026 Lee et al. Paper on the floating craniotomy.
Thanks for joining us on the Neurosurgery Hub. We hope this gives you some technical pearls for your next trauma call.
We'll see you in the next episode. Tighten those knots carefully.
And watch the ICP. Goodbye.